Thank you very much. Good afternoon, colleagues. And I'm the last speaker in this session, and then we can start engaging and talking. Just to give you a brief background of what's happening in South Africa, just to say, our causes of neonatal mortality are very similar to what you also find in your own countries. And our data shows that birth asphyxia is the leading cause of death, especially in birth weights above 2.5 kilograms. And then infection is the third largest cause of neonatal death in all weight categories. But the highest, the highest number of babies to be affected by infection are those between 1,000 grams to 2,000 grams. And then prematurity cuts across these two causes. Now, we monitor our data in South Africa, and I'd just like to bring you to the part that I've highlighted in red, because that shows us what our neonatal mortality rate is per 1,000 live births. So in 2009, our baseline was 14, and then in the last column, that's where we set our target for 2014, and we said we would have a 10% reduction and have the neonatal mortality rate at 12 per 1,000 live births. So what happened in 2010, we got a very slight drop, just 13, but then when we looked at our data again in 2011, we were back at 14, so it's very static. If you look at the row that talks to under 5 mortality, the under 5 mortality rate, in 2009, our baseline was 56, and we set our target to 50. But when we looked at the data in 2010, we had actually exceeded our target and we're at 53. 2011, we were even going further down and we're now at 42. So under 5, we're moving quite well, but it's the neonates that are not making any progress. So what opportunities have we got? Well, the first one is that our Minister of Health has appointed 3 advisory technical committees, and these committees have got obstetricians and gynecologists, they've got midwives, and they've got pediatricians. And the first of these committees is the National Committee on the Confidential Inquiries into Maternal Deaths, and this was established in 1996. The second committee is the National Perinatal Mortality and Morbidity Committee, and this was established in 2008. And the third committee is the Committee on Mortality and Morbidity in Children. And what these committees do is they conduct audits and they produce triennial reports. And the information generated from these reports is what we used in formulating policy. And they also investigate incidents. If we have, like, for instance, an unusually high death rate in any one of our hospitals, then this is the group that actually goes and investigates and makes recommendations for Minister. And then, as you all know, probably that South Africa is undergoing health reform. We're now in the process of establishing the National Health Insurance. And the aim of the National Health Insurance is to attain universal health coverage. We want to shift South Africa from a hospice-centric, curative healthcare system to one with a preventative and health promotion focus. And the principles of establishing this National Health Insurance is social solidarity, equity, and fairness. And the policy objective is to ensure that everyone has access to appropriate, efficient, and quality health services. And you know, this is a very big task, so it will require significant overhaul of existing service delivery structures, administrative and management systems. And because it's so huge, the intention is to phase it in over the next 14 years. So at the heart of National Health Insurance is what is called the re-engineering of primary health care. And this is the core of the NHI. And with re-engineering, we've actually established, this is something that we've actually done, is that there are what we call district clinical specialist teams that have been set up and employed. There are 52 districts in South Africa, so each district in South Africa is in the process of employing a district obstetrician, a district pediatrician, a district anesthetist, a family physician, an advanced midwife, a primary healthcare nurse, and a pediatric nurse. And then the second stream of re-engineering of primary healthcare is the establishment of what are called the municipal ward-based primary healthcare teams or your community health workers. So each district in South Africa is divided into a sub-district. Then within each sub-district, we've got the municipal wards. And then the third stream is what is called the Integrated School Health Program. And here we've revitalized the whole school health program where we're actually taking services to schools. And part of the package that we offer is sexual and reproductive health. And then CARMMA, which is an AU-inspired initiative, we've got our version of CARMMA in South Africa. And what we are prioritizing in CARMMA is scaling up contraception, early booking, we're scaling up our PMTCT, and then we're putting in dedicated obstetric ambulances. These ambulances are only for pregnant women and mothers. Nobody else can use them. If there's a road traffic accident somewhere along the route, obstetric ambulances can't go there. They are only for our mothers. And then we've got a training program called the ESMO-E, which we are rolling out in the whole country. And then one of the other elements of CARMMA is that we are planning to have, to increase our number of skilled birth attendants and increasing the number of midwives. We're also improving our newborn care and treatment. We're also establishing kangaroo mother care throughout all health facilities and hospitals especially. And then we're also putting up lactating mothers' lodges wherever there are pediatric wards. And then intensifying our coverage of lifelong antiretroviral treatment to mothers whose CD4 count is less than 350. So we've just finalized our neonatal survival strategy, and we're calling it the happiness strategy. So the A is that we're going to improve the health system for mothers and babies. The next H is to improve the knowledge and skills of healthcare providers. And then we have to reduce deaths due to asphyxia, prematurity, infection. And then the NESS at the back at the bottom stands for newborn survival strategy. And then we're linking up with what is happening in our maternal health strategy, and they've got 5 H's. So they're saying that we should reduce our deaths to HIV and AIDS, deaths to hemorrhage, hypertension. We need to improve our health worker training and health system strengthening. So if we combine these two, ultimately we should improve the neonatal health outcomes and maternal health outcomes in South Africa. And then our strategy, if you look at the left side, we've got the key causes of mortality, and we've divided those into those larger areas that need to be looked at. So it's the health system, the knowledge, and then look at what you specifically for deaths due to asphyxia, what do you do specifically for deaths due to prematurity, and then deaths due to infection, a whole package of services clearly outlined. And then we would learn a lot of lessons from what we did with PMTCT. And just to remind everybody that the improvements in PMTCT is the single most important reason for the declining child mortality rates that I showed you in that table. And now we have in place the elimination strategy, or the EMTCT. And then if you look at how we have performed in PMTCT, this is a measurement at 6 weeks. In 2008, we're at 8%. In 2010, we're at 3.5%. And 2011, we're right down to 2.7%. So the PMTCT, the new guidelines, have just been launched. Today is the 15th of April. They were launched at the beginning of this month. And what do we have there is that we now have a fixed dose combination triple therapy tablet for all pregnant women to take, for prevention of mother to child transmission, but also for their own health. And for those who don't need ARVs for their own health, they will take the tablet until they stop breastfeeding. So regardless of CD4 count, it's ARVs for all pregnant women, and then lifelong ART for CD4 less than 350. So I just put in a pack the priorities of the priorities. When we do our planning, we know exactly what it is we should target. And then how are we going to operationalize our strategy? Well, we are planning to establish teams and focal persons to actually lead in the implementation of this strategy. And each team within the district or the health facility must assess the situation and look at the bottlenecks, because it's not the same causes throughout the facilities throughout the country. Your plan has got to be customized to meet the bottlenecks in your particular area. And so from there, after doing the bottleneck analysis. We need to develop costed evidence-based plans and a training plan, because the training is inherent in expanding this guideline. But just the green box right at the end is that each team needs to document their best practices and the lessons learned, and then there will be a lot of benchmarking and expansion taking place. So the key challenges in all this is the community education and demand for services. Our services must be acceptable to our community members. And then access to care, there are many barriers, from staff attitudes to long waiting times to the cleanliness of the facilities. All that actually needs to be addressed. And then the essential equipment. It's not just the equipment for neonatal resuscitation, but basic things like the blood pressure machine, the hemoglobinometer, the scale, those have also got to be there. And then quality of care, that is key. And then the training, like I said, has to be in the plans. And then monitoring and evaluation. I cannot say any more on that. I think we all know that what gets measured actually gets done. Thank you.